So it says it's recording. So got it. So I am thrilled to kick off the Immunology and Cancer Vaccines virtual seminar series for the Cancer Vaccine Institute. As you can see throughout the course, we're going to move from the immune system in cancer, which today is mostly an introductory topic to how the immune system works and a bit about how it interacts with cancer. Nora next time will give the using the immune system to treat cancer talk, and then we will move into specifics about preclinical development of vaccines, breast cancer vaccines in clinical trials, and then vaccines targeting gynecological cancers throughout time. So I'm going to get going, and in truth, if you have the chat feature ready to go, or if I'm at a moment where you think something's unclear, you should feel free to type that into the questions and I'll try and pay attention to that. So as we said, I am going to talk about the immune system in cancer, and this is kind of a basic overview. And when truly I start with is this cute picture that I took off the internet from Baylor, which has in it cancer cells being attacked by T cells. And that's going to be one of the themes as we go through, interacting in what the cellular function is and how this works. So my outline for today is I'm going to give you a one-slide history of how far back using the immune system to fight cancer really goes. And then I'm actually going to spend most of my time on what I usually call the immune system primer. I'm going to briefly talk about the immunoscore and clinical picture where using the immune system to measure cancer recurrence is useful in a setting. And then go back to talking about immune system in cancer and how it interacts with focusing a little bit on what tumor mutation burden and that concept, recognizing cancer and why it doesn't always prevent cancer, because saying the immune system doesn't prevent cancer is probably inaccurate. It's just the patients who develop cancer, the cancer has gone around the immune system. And then we'll briefly talk about types of immunotherapy or where they interact in the system. So using the immune system to fight cancer goes back to 1891, and it was reported in 1891 and then again in 1893. In 1893, William Coley published the treatment of malignant tumors by repeated inoculations of erysipelas, which is, I believe, a strep infection, with a report of 10 original cases. And the paper starts pretty much with saying, he cites his previous paper in 1891, where he published in the Annals of Surgery, he referred to at length the curative effect of erysipelas upon a sarcoma. So he had a patient who had sarcoma who had an infection and then did very well. So the observation that post-surgical patients who acquired infections had improved survivals led to the treatment of cancer patients with killed bacteria, which was named after him of Coley's toxin. And the idea, as you'll find out, is that just by throwing dead bacteria into patients, that caused inflammation and in some patients improved their overall survival. This up to about, even when I started, when I was in fellowship, so that was about 12 to 15 years ago, we were using, at that point, not Coley's toxin, but stimulating interleukins to drive the immune system to treat melanoma and kidney cancers. And then with the advent of more modern immunotherapy, which people read about, of checkpoint inhibitors, which we'll get into, that really kind of stopped using, I would say, as much, the hormones and the chemicals, and trying to drive a little bit more specific of the response of where we need it. So I'm now going to jump into really the focus of what I'll talk about for a bit, which is the immune system primer. And in that, we come to this slide. I have many buttons, so I'm going to try and find my little pointer. So immune system cells are derived from stem cells in the bone marrow. So it all starts with a pluripotent hematopoietic stem cell in the bone marrow. And then that derives all these other cells. So breaking this down a little bit, this bone marrow stem cell does make things which we're not going to focus on for most of the time, but it makes something that will generate your platelets, which is what stops you from bleeding, and it generates your red blood cells that carry oxygen. So that's your platelet count and your red blood cell count, your hemoglobin or hematocrit if you've looked at your labs. And then the majority of the rest of the stuff that I'll come to is really kind of white blood cells. And the first white blood cell group I'm going to talk about is really what's often called the myeloid cells, or somewhat about what we'll say is the innate immune system. These are cells that are ready to do something to cells that have viruses in it or bacteria automatically. So in this system, the dendritic cells are what we call professional antigen presenting cells. So these cells take up things like bacteria, frankly, rip them apart and then show this to the immune system. There is, in addition to that, and we'll talk more about that, there's also other white blood cell counts. If you've been unfortunate enough to receive chemotherapy, you've heard a lot about your neutrophil count. Neutrophils are what fight mostly bacteria. And then you hear about some of these other things less often, but there's monocytes and macrophages. And macrophages are cells that also, once again, take up things that come into the body and then present it to the adaptive immune system. So when we talk about, to some extent, adaptive immunity, you're looking at a bunch of lymphoid cells to some extent. Now, NK cells stands for natural killer cells, and once again, those are innate and are able to, from the beginning, attack things. And then you have T cells and B cells. T cells are generated throughout your body and are designed to really go after, I'm going to say, random findings that your body removes the ones that it would attack yourself. And B cells are what make antibodies. So those are the main parts of the immune system as we look at what is happening on a cellular level. So infectious agents first activate the innate immune system that results in an inflammatory response. And when I talk about the immune system, I'm going to first talk about it in the sense of how it reacts to infectious bacteria and viruses. And then I'm going to talk about how that parallels, in a way, what cancer is. So in this case, in this picture, what you're seeing here is how bacteria will get uptaked into macrophage. The macrophage will essentially, we'll say, eat it. And this causes it to release cytokines and chemokines. So that sounds a little technical for those who may not know, but a cytokine is a protein that immune system cells use to communicate or regulate other immune cells. Not all cytokines are necessarily inflammatory. Chemokines are a group of cytokines that attract other immune cells. So as the macrophage gets activated with this bacteria, it gives off these chemicals that then will increase or cause vasodilation, so bring in some more blood, increase vascular permeability, which is the way to say cells will be able to get out of the bloodstream and into the area where the bacteria might be. The permeability then causes what, if you've ever had a little skin infection, the redness, the heat you feel from all those cells coming in and the swelling. So this is what happens on that microscopic level, is that the blood flow is coming right in and causes all that inflammation. Inflammatory cells migrate into the tissue, releasing other inflammatory mediators, and that's what causes it to start to hurt. It's also what causes the immune system to be there and is able to, brings in all those immune system cells to get rid of the bacteria or whatever's causing the, what could cause an infection in that area. So jumping a little bit at this point to a virus infecting a cell. In this picture, what you see is a virus infects the cell and gets put into the cell. The viral RNA or DNA gets processed and makes the virus proteins. These proteins get put onto ribosomes, which isn't necessarily all that important to remember for the purpose of this. It then goes into something called the endoplasmic reticulum, but really what happens in this area is these proteins are chopped up into little pieces called peptides and then get stuck into MHC molecules, which stands for major histocompatibility complex. And we don't really have to remember that either, but it's an MHC, and there's something called class 1 and class 2, and we'll talk about that. These MHC molecules are expressed on all nucleated cells. So all the cells in your body process everything the body makes and puts it on the surface of the cell, and roughly puts it there to be seen by the immune system. As I said, the immune system is floating around with T cells to see what is around and just doing general surveillance. These kind of proteins are recognized by NK cells and such. So once again, you can think of this DNA that in this picture is put in by a virus, but it could also be an abnormal protein or a cancer-driving protein or an abnormal cancer protein that also gets chopped up, processed, and put onto the surface of the cell. There is something called MHC class 2 cells. These are typically in what's called professional antigen presenting cells, which are like those macrophages and what we talked about briefly, dendritic cells. So these present peptides derived from exogenous proteins. So where the MHC1 was looking at, like a virus, which is essentially made by your body, or if it was a cancer protein or cancer mutated protein, these are the ones that takes in the bacterium, chops up that bacteria, where the bacteria infects the macrophages, enters in, gets broken up. The bacterial fragments are bound by the MHC class 2 in these vesicles, and then that once again is put onto the surface of the cell for other cells to see. In B cells, the antibody can bind peptide fragments that are floating around, get internalized, degraded, which means chopped up, and then once again pushed up to the surface to be seen. So MHC class 1 are presented usually to such things such as CD8 cells, and we'll talk about those. And MHC2 presents antigens to CD4 T cells. And I always remember those, if you want to remember the pairing, but it multiplies out to 8. MHC1, CD8, MHC2, CD4, and then you get an 8. So trying to put how all of this works together, because though initially thought about somewhat separately, you get the adaptive immune response. So a foreign body gets taken in this picture by a macrophage or a dendritic cell. It is presented then to the CD4 T cells. The T cells, or then these cells could be what are called helper T cells. It will then drive via chemicals to bring in the T cells that actually attach to such cells that are infected, which are called cytotoxic T cells. It attaches to either a cell that has the virus in it, potentially the cancer in it, and it becomes activated, both co-stimulatory molecules, and then would tell that cell to die. And that's how it gets activated and then does its job. It can also then make B cells and make antibodies, and those antibodies then can drive internalization and an immune response through another system that activates things called complement. So it's really helping your body identify things that, once again, aren't you, such as a virus, and then ways for your body to remove it. So briefly, just to show you how there's an attempt to use what your immune system is doing with cancer, I'm going to talk a little bit about something called the immunoscore. So the immunoscore was mostly looking at, or it's the biggest looking at, colon cancer. So what this is a picture of is an invasive cancer, and there's areas of this cancer, which is in this area over here, where it is near the invasive margin, which means it's the cancer as it approaches normal tissue. And there's areas of this which are at the center of the tumor. And what they did is they designed an electronic capture system and quantification of the measurement of cells. So there's a stain that gets put on, and the machine then can capture and calculate how many T cells there are per an area. And what this does is it predicts what your outcome is, just showing you that the immune system response to cancer is important. And as I've said, if your immune system eradicated cancer before it really became clinically apparent and seen, you never know, and no one knows that there was any cancer cells that got destroyed by your immune system. But this little slide, if we focus on this little area for a moment, colon cancer is normally staged 1 through 4 by how invasive the cancer is locally, and then how far it spreads into lymph nodes and then into other organs, similar to many cancers. And though not perfect, overall, the higher the stage, the worse survival is. And what this curve and this other curve is looking at, just so we know, is at time 0, you have everyone is, in this picture, cancer-free and alive. And then as you go this way, time moves on to, in this slide, 180 months, which can't do the math quickly, I guess is 15 years, I think. 120 months would clearly be 10 years. And what happens as far as the line goes down every time either someone's cancer came back or they passed away from whatever cause. And what they're trying to show in this picture is that if there was a high immune response in this point in the center of the tumor and at the edge of the tumor, that whether you were stage 1, 2, or 3, you frankly did pretty well. These groups aren't very different over time. And if there was not a good immune response, it was a low T cell response, then those patients did worse than the other group. So what they're saying is that more important than stage is what is the immune response to the tumor. This is just showing another evidence that the T cell response to a tumor matters. And then the question becomes, how can we use that? How can we generate these T cell responses? This is the stage 4 group, and those patients in both groups do similarly disparately by whether or not they have an immune response, but do worse overall, as kind of one would expect. There's a little bit of a circular logic, kind of as I talked about. You kind of have to get a big picture and then kind of delve into it so you can see how things interact. And as T stage goes up, so as the tumor kind of gets worse, the amount of immune system cells decrease. So this is showing higher T stage or a more invasive cancer. And as you do that, the amount of immune system cells fall. This is also looking at that in a similar way, showing that there's a correlation between how that goes. So what, to some extent, if you're looking at a higher stage tumor or a more invasive tumor and they do worse, the immune system also falls off in that picture. So it's a little bit circular of where those things are, which comes first. But in the end, the cancer does have to evade the immune system. And I will talk about that also in a little bit. Once again, just showing you how the T stage and relapse correlate. These minus signs were saying whether or not someone did or didn't relapse. And this is looking at how much immune system cells there were. And to some extent, this is showing you that if you had this many T cells in the different stages, none of these people relapsed. And in this group, if you had, here it's hard to see, but they didn't show really any immune system cells. And then here you had lower ones, all of these people did relapse. So these two groups aren't drastically different. So there is overlap. But it is very predictive of whether or not the people relapse is what their immune system is doing to the cancer. Once again, if you have questions, you should feel free to ask. At the moment, we will be ending early before 4 o'clock. So the extent of the intratumoral immune reaction correlates with tumor stage in patients who did not relapse. And the number of T cells was low, regardless of the T stage in patients who do relapse. And this picture is just once again showing what I've already gone over, so I'm going to pass on. So going back to the immune system and its interaction in cancer. So we're going to talk a little bit about, and we use a lot of 1 and 2s, a type 1 and 2 response. And I guess the simple way to think of it to some extent is type 1 is the response we want the immune system to generate towards a cancer, and type 2 is not. And really where this is going to come into is that the body, whether it be in a cancer cell or an immune system cell, has checks and balances. So as something starts driving up an immune response, your body eventually has to calm that immune response back down. So if you start an inflammation process, eventually too much stimulation of inflammation starts to drive something that will calm it down, or the other cells will drive a response that calms it down. So in a type 1 response, you have what's a Th1 response, and those are the T helper cells giving off cytokines and chemokines that will drive something that makes it to where there aren't tons of blood vessels growing in, but might make them leakier. It is directly something that can damage cells, so it can damage cells that have viruses in it, can damage cancer cells, and is what your body uses to survey or to do its immune system surveillance. So as it's going around, if it sees a little bit of cancer, or if it sees a little bit of a few cells with viruses, this is what early on drives an immune response. Whole basis of vaccines is the idea that we're going to have this lying around in your body ready to go and to then react. Now, if the immune system starts revving up too much, or if there's other chemicals that something like cancer could generate, you start getting what is this type 2 response that starts developing blood vessels that the tumor can use to grow, starts tissue remodeling, and starts suppressing the immune system. So you get these type 2 responses, and you get what's called a regulatory T cells. So T cells are a big part of your immune system. That is what, it isn't what fights bacteria, but generates what can do. And when you have an autoimmune disease, what you have is T cells that are usually overreactive to your own self and body. So this is the type 2 response. So it somewhat splits off as a polarized response that's pro and anti-tumor. And when the host response to neoplastic cell growth presents with the Th1 response, it programs tumor regression. And again, when you get this adaptive immune response, and includes chronic protection, you eventually get to immunosuppression, and that contributes to tumor progression and metastases. So again, I've already shown this slide, but once again, I want to think about cancer, or the mutated protein cancers derive, as something as is akin to what a virus could be, or really foreign DNA or RNA. Because an abnormal protein in your body, or an abnormal enzyme that's driving cancer, is now abnormal. And though the change might be small, it is that abnormality that allows your immune system to do it. I have a question, so let me read it. Right, so exactly. I'm going to jump back to this response. So right, so it's the type 2 response that actually worsens cancer, and it's the type 1 response which helps cancer get smaller. And cancer cells find a way to, either through chronic stimulation, drive you towards the local response of this type 2 response, or gives off its own chemicals that just stimulate more regulatory T cells or more type 2 response. So if that didn't answer your question, please type it back in. But it's exactly, cancer drives this type 2 response. So when we look at cancer and they further characterize the T cells or the myeloid-derived stem cells and things like that, what we find when we get better analysis of those is that you see that it's a type 2 response. Yes, exactly. Basically, cancer drives immune suppression, so cancer can progress. Excellent question. So what this was showing you is, once again, just as a reminder, the mutated protein or abnormal one gets processed and puts onto the surface of the cell. So talking about what does the immune system see in cancer? And if we look at what it can potentially see, first, self-signal. So you can have aberrantly expressed normal things with overexpression. So if you think about breast cancer, there is HER2 overexpression in some patients. And when it's overexpressed at such a high level, your immune system might see more of it than is expected, and that can then be aberrantly expressed in something that can be seen. In addition, sometimes proteins are just outright mutated, and when they change, that alteration or modification can potentially be seen as abnormal and can be seen potentially by the immune system. And then you can have foreign signals. Now that can come in by, once again, a virus, or once again, a mutated protein that is shown is presented by the MHC molecules and presented to a T cell. This over here was technically showing you post proteins that are modified in abnormal ways, and this is kind of showing you an initial modification. So what most commonly happens, however, is that this chronic stimulation leads towards the immunosuppression and more regulatory T cells, which are here in blue, and cool off the immune response locally. And what happens less commonly is you have T cells that are effective fighter of cancer and are the effector T cells that can get rid of the cancer. So that's what happens in what cancer develops. So you don't either see a whole lot of T cells, or what you end up looking at when you have these cancers is a whole bunch of T cells. So let's talk a little bit about tumor mutations and what that is. So this, which is a little confusing, and I'll to initially see, but I'm going to drive you through this picture. So there is DNA and RNA, which are really, there's only 4 base pairs. And you get a sequence of these that eventually makes an amino acid, and a bunch of amino acids together make peptides and then proteins. So there's 3 parts of DNA or RNA that then drive towards a specific amino acid. And not every change actually changes what amino acid is done. So DNA changes, which is what happens, and is to some extent the hallmark of cancer, to make an abnormal protein or enzyme that is driving the cancer, is if you took a mapping, if you started with a U, and then you had a C, and then you have any of these letters, you end up with this amino acid. Now, if you take this thing and it changes to that thing, it doesn't actually matter what this DNA changes, because you still end up with the same amino acid. So in this case, you don't really change anything. But you can see in other locations, if you change one of these amino acids, you can have a drastic shift to a different amino acid, or that would change the protein. Or you could get what's these black things, which are stop codons, and that just stops the entire rest of the translation of the protein. So you can have a very long protein, and if you get this change to what's called a stop codon, your protein, which is normally this long, gets cut in half. And that half can be what regulates the cell. It takes the signals to slow it down. So that's something that's, when you look at it, is measuring, you can measure this amount of change. And the more mutations you have, in truth, the better chances that immunotherapy will work. So measuring the amount of change that's in a cancer cell is what's called, in the end, tumor mutation burden. And this is somewhat predictive of where immunotherapy, mostly when we're looking at what's called checkpoint inhibitors, those drugs are like pembrolizumab, nivolumab, trade names of Keytruda and Opdivo, which is now on the news everywhere. But the tumor mutation burden is what gives your potentially increases the chance your immune system can see something. This is essentially saying there is, one mutation per blank number of pieces of DNA, or there's 100 mutations. And what this picture kind of is supposed to show you is it has various cancers listed on top, and it shows you, sequencing a bunch of them, what is the mutation burden. And to some extent, where you look at where the drugs that are out that we think of as immunotherapy, which are the checkpoint inhibitors at the moment, I've highlighted which cancers are clearly where it's been approved, we'll say. And it doesn't respond, everyone doesn't respond, but what you can see is there's a clear shift towards approval for drugs where the mutation burden is overall higher. Now, some of these are, some people don't respond. And the question, of course, is it these people who don't have a high tumor mutation burden? And it's not black and white, because to some extent, it's the quantity, or what we say quality, of what that mutation is. So if you just have a mutation that really your body can see, then that's all you need. So to some extent, it's more of the higher the mutation burden, the better the chances that your body can see something. So I always find that just kind of an interesting view of that area. And then just so we can think that when you look at a group of people, and this group all, I believe, had lung cancer, and you looked at tumor mutation burden, if it was less than 10, there are some people who respond, but it's always at about this number. And then as you get a higher mutation burden cutoff, above some cutoff, the response rates go higher. So if we actually thought of, tumor mutation burden cutoff of 20, what you can see is if you use the above 20, in truth, in this group of people, the response rate was 40%. And it's just showing you that the more abnormal proteins you have, the better the chances immunotherapy can work. So tumor mutation burden differs across tumor types to some extent. And just as an example, if you looked at all prostate cancer patients, the general range of tumor mutation burden is this low number to 14. And in bladder, it's from this low number to 100 almost. So this is where, what we're looking for as far as mutations come into play. So going to, now that we've talked a bit about mutations, it's like, how does the immune system recognize cancer? So let's go through kind of like a cycle of what can happen. So starting here with this 1, a cancer cell can release antigens. And this happens when the cancer cell dies and usually falls apart, and your body does what it does with those cells, which is clean it up. Now, cancer cells can die, I would say overall, by 2 main mechanisms. One would be chemotherapy got in there and killed it, or it's just outgrowing its blood supply and cancer kind of falls apart because it's not in the nice, healthy, organized way that it should be. So when this cancer cell breaks apart, the presentation in something like those antigen presenting cells or dendritic cells, these professional cells, go in there and clean it up. They migrate to the lymph nodes and show the lymph nodes and your lymphocytes these abnormal proteins. It makes T cells that then, there's T cells that then are generated and are trafficking through the blood vessels to where the tumor is. There's then an infiltration of these T cells into the tumors. There's a recognition of cancer cells by these T cells, and then these T cells kill the cancer. And that would be the immune system successfully getting rid of the cancer. And when this doesn't work well is when either there is not generation of these T cells, or when locally there's an immunosuppression. So jumping to my next slide, why doesn't the immune system prevent cancer? Or why does it fail to prevent cancer 100% of the time? So there's many mechanisms by which tumors avoid immune recognition. So one is just low immunogenicity. There could be a few things. So there could be no peptide that really binds to the MHC, that molecule that shows it to the immune system. There could be a lack of adhesion molecules for that T cell to bind to the cancer cell. The cancer cell can lose that. Also, your immune system sees things in both a stimulatory and a lack of stimulation. So if a T cell comes to the right location and there's no molecules that are ready to stimulate that T cell, it might make that T cell think I shouldn't attack and drive it down, versus being in a stimulatory way and then generate that immune response. So the tumor could be treated as self. Tumor antigens taken up and presented in the absence of those co-stimulation makes the T cell say, oh, this is you, I shouldn't do anything. And then that T cell removes itself from the population. You can have modulation of the antigens. So antibodies against the tumor cell surface can induce these abnormal proteins being sucked into the cell and degradation of this antigen, which your body might be able to recognize. And then you get the variants that are left of the cancer cells, are the ones that your immune system can't see. And kind of as mentioned earlier, tumor-induced immunosuppression is a very big part of it. This is where chemicals are given off, such as tumor growth factor beta, that's secreted by the tumor cells and inhibits the T cells directly and induces those regulatory T cells. This is that type 2 response we were talking about. So the cancer literally gives off hormones to drive immunosuppression that then drives its own growth. And then it can also be in a tumor-induced privileged site, which either means it's somewhere where cancer immune system cells don't typically go, or it literally creates a physical barrier that T cells can't get through. It can put kind of like scar tissue around it. So looking at the next slide looks at the microenvironment favors immunosuppression. So here we go, looking at that, where once again, I just talked about a physical barrier. We call that stroma. You can think of it as collagen or scar tissue almost. Literally, it just goes around the tumor and doesn't let the immune system really get into it. That can be driven by fibroblastic cells. There are what's called myeloid-derived suppressor cells, which we also just call MDSCs, because doctors and people who study things just love acronyms. And these myeloid-derived suppressor cells are literally, they're kind of myeloid cells like we talked about at the beginning, of things that would come from the bone marrow and then are derived here and then end up in the tumor and suppress the immune system. So despite macrophages and other things coming in, it drives these cells to not stimulate the immune system, to become tolerant at the tumor. And then here you have a cytotoxic T cell trying to get in and do its stuff, but it's either blocked or shut off by this system. So my next slide is jumping to what I say is types of immunotherapy. And I talk about that in two different slides. One is looking at T cells. So again, if we go back, you have those cells that literally just fight bacteria and kind of cause inflammation. And then you have T cells, which are the ones that a cytotoxic T cell is the T cell that literally would come along, bind to the cancer and removes it. Kind of like that initial picture that I had in the bottom of my introductory slide. And the immune system, once again, like everything else, it's about check and balances. So there are inhibitory molecules on T cells that, when are stimulated, shut it down. And these are here because you can't just let T cells go crazy. And if the T cells were attacking yourself, you want to be able to bring that down. And then there's activating things that when you stimulate these side of the T cells, drives the T cell to respond. And your body tries to balance these, and the cancer cells just try to inhibit this. So when the T cells are there, you have inhibitory receptors that are usually being stimulated. And what a lot of therapies try and do is block that. Now that's all well and good if you have a T cell response of some sort. So this is where I really talk about, in general, types of cancer immunotherapy. And just walking through that same slide that I went through earlier, we talked about release of cancer antigens. So how can we get that in what might be an immunostimulatory way? That might be with chemotherapy, might be with radiation therapy, or other targeted therapy drugs that would stimulate these cancer cells to die. Now, in addition, you can have cancer antigen presentation. Now, there are some molecules that are called TLR, which are something your body has a built-in system to want to cause inflammation to, and that can stimulate just an immune response natively. You can have other drugs such as anti-CD40, which is an agonist, despite being said called anti, but drives this presentation. You can give chemicals like interferon, which once again is a pro-inflammatory thing. There's GM-CSF, which brings in macrophages and stimulates the immune system. And then there's vaccines. So this is kind of where vaccines go and are taken up by the antigen presenting cells and stimulate that immune response. Now, once you're in this lymph node, there's other hormones, which I'm not going to list them all, but this is what drives, once again, trying to create that immune response and make it a pro-inflammatory molecule, and make it a pro-inflammatory environment, so cancer and immune response is driven. The T cells then, kind of as far as we know at the moment, traffic on their own, doing something with the blood vasculature, targeting vascular endothelial growth factor may affect T cells getting into the tumors. This then hopefully drives into making a T cell that your body can generate on its own if you use earlier. This is where when you hear about something called CAR T cells or transgenic T cells, what you're trying to do is roughly bypass the need for these steps and take a T cell out and put it right into the cells, the T cells, so it can then attack a cancer. And then once you have the T cell there, the question becomes, do you need something that blocks the inhibition that the cancer might drive? So the question becomes, do you need one of these? Do you need multiple aspects of this? And I need to jump for a second to, there we go, okay. Do you need multiple aspects of this? So what we're trying to do is turn what we call a cold tumor to a hot tumor. So the immune system, T cells, we know can fight cancer. We know if there's a lot of T cells, it can attack it. We have a question of whether or not it's the quantity of the antigens the tumors develop, or whether it's the quality of the antigen. Do you just need to find one good one? And then what we're trying to do is turn cold tumors into hot tumors. So in this picture, what you see is there's some tumor cells in here. There's a lot actually in the mass that's what we call cancer, that's not just tumor, but is sometimes immune suppressing cells, is other structure, is things that dampen that down. And what we're going to try and do is generate a way to make this cold tumor, something the immune system can't fight, into a hot tumor where T cells and other cancer fighters can really get in there. And that, in truth, is the end of my talk. So I will stop sharing for the moment. People can feel free to turn on their cameras, turn on some mics, or type in their questions, and we can see how all this goes. And if I need to bring the slides back up, I'm happy to.
Thank you, Dr. Coveler. Any questions?
Yeah, I had a quick question. I was very excited at the last slide about how you're bringing the cold tumor to hot tumor. I'm a student at Bellevue College. I'm graduating this quarter with molecular biosciences. This is something I'm doing, really studying through books in immunology itself. So it's really interesting to see how you're bringing the cold tumor to hot tumor with T cells. Are you bringing in the T effector cells, or are you bringing in with the T effector memory cells? I don't know. I'm just curious. Sorry.
Right, no, that's a fantastic question. And throughout this series, I think we're going to talk about how we try and generate both those effector cells and memory cells, the helper cells in both aspects of it.
One of the things, Prabin, that I think it's important is recently people have found out that the less differentiated the T cell is, the more functional it is. So if you have a very differentiated memory T cell kind of at the end of its lifespan, that is not going to be as effective as a cancer killer as a very early T cell that still maintains some of its stem-like qualities.
We got a question in the chat that said, wouldn't it be important to first reverse the immunosuppression in the tumor prior to vaccine immunotherapy? It's a good question on the exact sequencing. I think in the end, for some tumors, you're going to need both parts. For a lot of what we do and what we talked about is really trying to bring the vaccines in when there's minimal to no large tumors, which have a much less immunosuppressive environment, so you can attack minimal cells. But that's where things we're going towards is seeing how do you both generate, maintain, and then make it to where those T cells can actually do something. Are there any other questions or things to clarify? I'm sorry, I see two people on mic, but we can't hear you.
I'm not sure if it was a question.
Okay.
It may have just been a hot mic.
Might just be a hot mic. Okay. All right. Well, hopefully you now understand the immune system well, if not better than before. And I want to thank you for sticking with me.
Thank you, everyone. Please do join us next week where Dr. Nordesis will be talking about how we use the immune system to treat cancer. It will be a very fun presentation. See you all next week.
Thank you, Dr. Coveler.
My pleasure.
Thanks, Andrew.
Look forward to seeing everyone next week for Nora's talk.